In this final section of the chapter, we're going to talk about how it is that you recover from brain injury. So we've talked about plasticity and how the brain adapts. That plasticity was generally referring to how your brain adapts to experiences. The plasticity involved in recovering from a brain injury builds on the same principles of the plasticity that occurs as you just go about and learn things and interact with your world, but it can also be a little bit different because it can really stretch what plasticity your brain is actually capable of. So we're going to watch here a brief video and then discuss brain injury and recovery from brain injury in greater depth.
In this talk, I'm going to give you the single most important lesson my colleagues and I have learned from looking at 83,000 brain scans. But first, let me put the lesson into context. I am in the middle of 7 children. Growing up, my father called me a maverick, which to him was not a good thing. In 1972, the Army called my number, and I was trained as an infantry medic, where my love of medicine was born. But since I truly hated the idea of being shot at or sleeping in the mud, I got myself retrained as an X-ray technician and developed a passion for medical imaging. As our professors used to say, how do you know unless you look? In 1979, when I was a second-year medical student, someone in my family became seriously suicidal, and I took her to see a wonderful psychiatrist. Over time, I realized that if he helped her, which he did, it would not only save her life, but it would also help her children and even her future grandchildren, as they would be shaped by someone who is happier and more stable. I fell in love with psychiatry because I realized it had the potential to change generations of people. In 1991, I went to my first lecture on brain SPECT imaging. SPECT is a nuclear medicine study that looks at blood flow and activity. It looks at how your brain works. SPECT was presented as a tool to help psychiatrists get more information to help their patients. In that one lecture, my 2 professional loves, medical imaging and psychiatry, came together and quite honestly revolutionized my life. Over the next 22 years, my colleagues and I would build the world's largest database of brain scans related to behavior on patients from 93 countries. SPECT basically tells us 3 things about the brain: good activity, too little, or too much. Here is a set of healthy SPECT scans. The image on the left shows the outside surface of the brain, and a healthy scan shows full, even, symmetrical activity. The color is not important, it's the shape that matters. In the image on the right, red equals the areas of high activity, and in a healthy brain, they're typically in the back part of the brain. Here is a healthy scan compared to someone who had 2 strokes. You can see the holes of activity. Here's what Alzheimer's looks like, where the back half of the brain is deteriorating. Did you know that Alzheimer's disease actually starts in the brain 30 to 50 years before you have any symptoms? Here's a scan of traumatic brain injury. Your brain is soft and your skull is really hard. Or drug abuse. The real reason not to use drugs? They damage your brain. Obsessive compulsive disorder, where the front part of the brain typically works too hard so that people cannot turn off their thoughts. And epilepsy, where we frequently see areas of increased activity. In 1992, I went to an all-day conference on brain SPECT imaging. It was amazing and mirrored our own early experience using SPECT in psychiatry. But at that same meeting, researchers started to complain loudly that clinical psychiatrists like me should not be doing scans, that they were only for their research. Being a maverick and having clinical experience, I thought that was a really dumb idea. Without imaging, psychiatrists then and even now make diagnoses like they did in 1840 when Abraham Lincoln was depressed by talking to people and looking for symptom clusters. Imaging was showing us there was a better way. Did you know that psychiatrists are the only medical specialists that virtually never look at the organ they treat? Think about it. Cardiologists look, neurologists look, orthopedic doctors look, virtually every other medical specialties look, psychiatrists guess. Before imaging, I always felt like I was throwing darts in the dark at my patients and had hurt some of them, which horrified me. There is a reason that most psychiatric medications have black box warnings. Give them to the wrong person and you can precipitate a disaster. Early on, our imaging work taught us many important lessons, such as illnesses like ADHD, anxiety, depression, and addictions are not single or simple disorders in the brain. They all have multiple types. For example, here are two patients who have been diagnosed with major depression that had virtually the same symptoms, yet radically different brains. One had really low activity in the brain. The other one had really high activity. How would you ever know what to do for them unless you actually looked? Treatment needs to be tailored to individual brains, not clusters of symptoms. Our imaging work also taught us that mild traumatic brain injury was a major cause of psychiatric illness that ruined people's lives, and virtually no one knew about it because they would see psychiatrists for things like temper problems, anxiety, depression, and insomnia, and they would never look, so they would never know. Here's a scan of a 15-year-old boy who fell down a flight of stairs at the age of 3. And even though he was unconscious for only a few minutes, there was nothing mild about the enduring effect that injury had on this boy's life. When I met him at the age of 15, he had just been kicked out of his 3rd residential treatment program for violence. He needed a brain rehabilitation program, not just more medication thrown at him in the dark or behavior therapy, which, if you think about it, is really cruel. To put him on a behavior therapy program when behavior is really an expression of the problem, it's not the problem. Researchers have found that undiagnosed brain injuries are a major cause of homelessness, drug and alcohol abuse, depression, panic attacks, ADHD, and suicide. We are in for a pending disaster with the hundreds of thousands of soldiers coming back from Iraq and Afghanistan, and virtually no one is looking at the function of their brain. As we continued our work with SPECT, the criticism grew louder, but so did the lessons. Judges and defense attorneys sought our help to understand criminal behavior. To date, we have scanned over 500 convicted felons, including 90 murderers. Our work taught us that people who do bad things often have troubled brains. That was not a surprise. But what did surprise us was that many of these brains could be rehabilitated. So here's a radical idea. What if we evaluated and treated troubled brains rather than simply warehousing them in toxic, stressful environments? In my experience, we could save tremendous amounts of money by making these people more functional so when they left prison, they could work, support their families, and pay taxes. Dostoevsky once said, "A society should be judged not by how well it treats its outstanding citizens, but by how it treats its criminals." Instead of just crime and punishment, we should be thinking about crime evaluation and treatment. So after 22 years and 83,000 scans, the single most important lesson my colleagues and I have learned is that you can literally change people's brains. And when you do, you change their life. You are not stuck with the brain you have. You can make it better, and we can prove it. My colleagues and I performed the first and largest study on active and retired NFL players, showing high levels of damage in these players at a time when the NFL said they didn't know if playing football caused long-term brain damage. The fact was they didn't want to know. That was not a surprise. I think if you get most thoughtful 9-year-olds together and you talk about the brain is soft, about the consistency of soft butter, it's housed in a really hard skull that has many sharp bony ridges, 28 out of 30 9-year-olds would go, probably a bad idea for your life. But what really got us excited was the second part of the study where we put players on a brain smart program and demonstrated that 80% of them could improve in the areas of blood flow, memory, and mood, that you are not stuck with the brain you have. You can make it better on a brain smart program. How exciting is that? I am so excited. Reversing brain damage is a very exciting new frontier, but the implications are really much wider. Here is the scan of a teenage girl who has ADHD, who was cutting herself, failing in school, and fighting with her parents. When we improved her brain, she went from D's and F's to A's and B's and was much more emotionally stable. Here's a scan of Nancy. Nancy had been diagnosed with dementia, and her doctor told her husband that he should find a home for her because within a year she would not know his name. But on an intensive brain rehabilitation program, Nancy's brain was better, as was her memory. And 4 years later, Nancy still knows her husband's name. Or my favorite story to illustrate this point is Andrew, a 9-year-old boy who attacked a little girl on the baseball field for no particular reason, and at the time was drawing pictures of himself hanging from a tree and shooting other children. Andrew was Columbine, Aurora, and Sandy Hook waiting to happen. Most psychiatrists would have medicated Andrew as they did Eric Harris and the other mass shooters before they committed their awful crimes. But SPECT imaging taught me that I had to look at his brain and not throw darts in the dark at him to understand what he needed. His SPECT scan showed a cyst the size of a golf ball occupying the space of his left temporal lobe. No amount of medication or therapy would have helped Andrew. When the cyst was removed, his behavior completely went back to normal, and he became the sweet, loving boy he always wanted to be. Now, 18 years later, Andrew, who is my nephew, owns his own home, is employed, and pays taxes. Because someone bothered to look at his brain. He has been a better son and will be a better husband, father, and grandfather. When you have the privilege of changing someone's brain, you not only change his or her life, you have the opportunity to change generations to come. I'm Dr. Daniel Lehman. Thank you.
Okay, so I thought that that video was a great one for sort of illustrating the importance of brain plasticity overall, that the overall impact that changing your brain can have not just on your life, but on others. That's a TED Talk, so they didn't go into a whole lot of methodological details, and it's quite challenging to figure out, okay, well, what some of those brain fitness programs would be, and I'm not quite sure of the control conditions that were given or anything like that, but I like the idea of that video for its overall message, that you really need to look at what's going on in the brain to understand behavior. And while I think we're a bit further away from actually being able to really elucidate what is going on in the brain, how you can change it, how you can target the change of particular behaviors or try to change particular associations, I think that we are on the way to that, and that it is really important to look at individual differences in brain function and how it could be underlying individual differences in behavior that would then lead to some of the larger conditions that we as a society care a great deal about, including depression, anxiety, how we respond to stress, how we respond to food, everything from weight gain that can be associated with stress, how we motivate ourselves, things that are associated with creativity. So we have a lot that we can learn by looking sort of at greater depth in ourselves. But it's also something that as we do this, it's careful to keep in mind that the brain's not going to tell you everything, because we are a bit more than just the sum of our parts. So when we do recover from brain injury, though, what we do is we really try to capitalize on the plasticity that our brain is capable of, the change that we can have. So there's 3 ways to possibly recover from brain injury, and this is any type of brain injury. This would be trauma, that is generally considered the most common form of brain injury that is examined, but then we also have injury that could be a little bit more diffuse, such as cell death from Alzheimer's disease or dementia. So here's the 3 ways. So one is that we can learn new ways to solve problems. We can reorganize the brain to do more with less, and we can generate new neurons to produce new circuits. Lots of programs target different routes to brain recovery. They may target 2 of these, or they may target 1, but at present there's not a single program that actually targets all 3. I'll jump right to number C and let you know that we are currently trying to generate new neurons to produce new circuits, but that has pretty much only existed in the experimental phase. There are a number of programs that try to train our brains to learn new ways to solve problems. That after we have damage to one particular region of the brain, and that particular region was involved in behavior X, that we might then try to need to use other regions of the brain to do behavior X instead of that prior region. So this can happen for some types of behaviors, but not all. We can also try to reorganize the brain to do more with less. So again, this is a little bit building upon A, where when you reorganize the brain, you're going to try to form new paths. Again, getting one brain region to do it instead of another one. And returning to A, if we're trying to learn a particular piece of information, we can learn that particular piece of information in multiple ways. So if our brain is damaged and won't let us do one way, then we can try to learn or remember information in another way. So really, again, capitalizing on this adaptive flexibility and plasticity that our brain is really capable of. Most programs rely on routes A and B to recover from brain injury, but they're trying to generate new neurons to enable the recovery of lost circuits. Because if you recall, the peripheral nervous system can repair itself, but currently the central nervous system cannot. So to give you another perspective on recovering from brain injury, there's this idea of the three-legged cat solution. When a cat loses a leg, it usually is able to compensate. And it's not able to compensate by growing a new leg, but rather by learning how to walk with only 3 legs. And so this is a good analogy to figure out how your brain is going to function after brain injury. And so the challenge, of course, is if you do suffer from traumatic brain injury, or you've had an event that sort of negatively impacts your brain, then it can be challenging because you'd be like, well, wait, I want to just sort of regrow this leg. I want it to return back to the way it was. So the most challenging thing for traumatic brain injury patients is that they have to learn that they can't do it the way they did it before. They have to let go of some of that frustration, and they have to learn new ways to do things, new ways to sort of exist with the revised abilities of their brain. The same ability to compensate in this sort of three-legged cat solution is also present in humans. So if someone does lose a certain ability, such as being able to write with their right hand, then they might be able to compensate by learning how to write with their left hand. They will have to get over the fact, as I said, they can't sit there and, well, force their right hand to write anymore. That route is just not able. So again, that compensation process is really, really important. When you engage in this compensation process, then you're going to be trying to train the region of the brain that's involved in using your left hand to do some of the things that your right hand used to do. So at first it will be really awkward and really problematic, but if you push through that and realize that it's going to be a different process, and you have to be very, very patient, because some changes in the brain can happen quickly, but again, it took you a long time to learn how to write, and so it's also going to take you a long time to learn how to write with a different hand. In returning to the second route, which was basically forming a new path, so in response to the injury, the brain can form new connections and do more with less. And again, it should probably be able to go ahead and say instead, do the same amount with less. When you try to do the same amount that you used to do with less brain, the amount of recovery is increased significantly if the person also engages in some form of intervention. So you can try to have some sort of behavioral therapy or pharmacological therapy. So think of the fact if you were going to have physical therapy following an injury, so you can have the same type of therapy to try to form new connections so that you can do the same with less. So there's speech therapy or physiotherapy. Pharmacological therapies might include nerve growth factor injections or trying to actually take some amphetamines that stimulate the growth of new dendrites and synapses. Ideally, behavioral therapy and pharmacological therapy would complement each other. And then finally, the lost neuron replacement solution. So this would basically be sort of like, okay, the three-legged cat solution, I've sort of lost one of my legs and now I'm going to try to regrow that fourth one again. That's the basic idea of this lost neuron replacement solution. So at present, we really don't have much of an ability to do that. But there are some research that is really trying to investigate aspects of this process. Fetal tissue implantation, this has limited success to date. It's more situated for situations where only a small number of cells are needed. So for example, dopamine producing cells in the substantia nigra for Parkinson's disease patients. And I want to take a second here. Fetal tissue implantation, this generally refers to stem cell lines, and there's various ways that you can get stem cells. There are stem cells in umbilical cords, for example, or afterbirths. So lots of families, knowing the value of the umbilical cords in the afterbirth, following the birth of their own children, are actually saving. There are tissue banks where you can save the umbilical cord and the stem cells in the umbilical cord for later on if these are needed. And so that after you've lost some of these cells, then you can try to put in sort of new clean stem cells that would try to assimilate the environment, such as sort of assimilating the nearby neurons in the substantia nigra, so that they could produce some of the dopamine that would alleviate Parkinson's disease. Replacing lost cells is also being looked into through epidermal growth factor. This is a neurotrophic factor that stimulates the subventricular zone to generate cells that migrate into the striatum and eventually differentiate into neurons and glia. So it's possible that in the future, trophic factors may be useful in the treatment of a brain injury. It depends on the type of brain injury that you would have, but that basically, if you catch the brain injury at a certain time after the injury occurs, there could be an increased sort of receptiveness to new cells that would try to replace some of these lost cells. But again, at present, this research is a bit further from reality. Here are some examples of trying to apply this ideal but futuristic approach. So after a cortical stroke on the left, if you have an infusion of epidermal growth factor into the lateral ventricle of a rat, this induced neurogenesis in the subventricular zone. The challenge, of course, would be one in terms of location. So we can do all sorts of things with rats that we can't quite do with humans at present. And this happens to be a cortical stroke in a region that might actually be able to be reached more easily or closer to the subventricular zone. But this early research is really nicely suggestive of what might be possible in the future to repair central nervous system damage. So what happened in this circumstance is that after you infuse these epidermal growth factors, then the stem cells migrated to the site of the injury and filled in the damaged area and to the right. The challenge, as I said again, is trying to get the cells to migrate to the right place. The differences in complexity in human brains versus rat brains, the location of the damage with respect to the subventricular zone, and they've only been able to show this on a very limited number of cases so far. So hopefully this is something that will become more possible, and this technology will increase in its application in the next 10 to 20 years so that we can treat more complex central nervous system damage, such as recovery from traumatic brain injury and recovery from spinal cord injury. And this is the end now of chapter 12. So please take a moment to make sure that now that we've completed all of chapter 12 content, that you fill out all of the participation questions that are posted as part of this week's lecture series.